Okay, we were discussing the thyroid gland, and just a few slides to remind us what we're talking about here. Remember, the thyroid gland is shaped as a butterfly. It has two lobes with this isthmus connecting it. It's roughly 30 grams, so one of the larger endocrine glands in humans. And it's developed very early on, so 4 weeks, and by 12 weeks it's complete. It's essential for growth and development, both of the fetus and for maintaining homeostasis of metabolism. In terms of a side section, cross section, this is what it looks like. And remember, it has these distinct circles that we call follicles filled with the colloid. So we have these follicle single cell circles. In between the circles, these are the follicular cells, but in between the circles you have these parafollicular C cells next to blood vessels. And inside you have this material made up of what's called colloid. And inside the colloid is this iodinated glycoprotein, the thyroglobulin. Remember the train that comes from Shanghai to Nanchang with all these tyrosyl iodinated MIT and DIT molecules. And in this process, we have to have retrieval of, we have binding of TSH, production of cyclic AMP, retrieval of iodide, diffusion, conversion of iodide across, a conversion iodide to iodine by TPO, addition of iodine to the tyrosyl groups, production then of MIT and DIT on the TG, endocytosis of this large molecule, and cleavage in the lysosomes of T3 and T4, which are then secreted into the plasma membrane, or into the plasma, sorry. And then the system recycles itself using a deiodinase. Remember that 95% of the thyroid hormones that leave the thyroid gland do so in the form of T4, and it's considered a prohormone. At the target tissue, the deiodinase enzyme converts T4 to T3 or to reverse T3. T3 is the active form and reverse T3 is inactive. And the biological activity as T3 is about 40 times greater than that of T4, whilst reverse T3 is basically inactive. Up to 90% of the active thyroid hormone within the cell is in the form of T3. The plasma half-life of T4 is 6 to 8 days, while that of T3 is 1 day. So if we just think, if we were to measure thyroid hormones, which hormone should we be measuring, the T3 or the T4? You guys can think about that, and we'll cover that when we start measuring. So we've talked about the anatomy of the thyroid, synthesis of the thyroid hormones. We've talked about regulation via the hypothalamus and pituitary. And we've talked about generally the mechanisms of thyroid hormone and the biological effects in terms of homeostasis. And now we'll talk a bit about hypothyroidism and its treatment. So it's true that the thyroid gland is required for development, but it's not absolutely essential for life. That is, you will have abnormal development, and you will have physical and mental side effects, but it won't kill the individual. You will still, it's not lethal. But what we want to understand is what these side effects would be, and then how to avoid them when we have pathology. So here is a 10-year-old girl with severe primary hypothyroidism due to primary myedema. And this is on the left before treatment, and on the right after treatment. She showed up in the clinic, and the complaint was that she had poor health, that she was a very dull-faced, relatively obese. Her body proportions were not equal for a girl of that age. And at 10 years old, she had not lost a single baby tooth. As soon as she received treatment, thyroid treatment, which is shown by here, the thyroid treatment started, okay? You can see this is her growth, starts to plateau, and it was always below, very short, right? So here's 5% for those that can't see it. This is 90% growth chart. She was down here. They started thyroid hormone treatment. She lost 6 teeth in 10 months, and a dramatic catching up of her growth. And her bone age was 5 years. When she was 10, her bone age was only 5. And then her TSH receptor blocking antibodies were negative, and we'll talk about what those are and how you measure them. So you can see here, so this is what I mean. She wasn't dead, but she clearly was short, obese, and had severe developmental problems. They started treatment, right? And you could, with treatment, restore her to a 50% growth curve, okay? And 50% weight. What are some symptoms of hypothyroidism? Lethargy, tiredness, weakness, very dry skin, cold intolerance, doesn't always cold, facial puffiness, impaired memory, constipation, hair loss, mild weight gain, hoarseness, heavy menstrual periods for females, and deafness and nonspecific chest pain. Signs of severe hypothyroidism: you have a change in appearance, again, very puffy face, thick tongue, some edema, dry, cold, flaky skin, delayed relaxation of reflexes, diffuse hair loss, very coarse hair, bradycardia, so your heart rate is all over the place, depression, you get goiter down here in the chin, signs of medium nerve compression, so carpal tunnel, You have effusions, ascites, croaky voice as well, and rarely a stupor or a coma in very rare cases. So patients with a goiter, the problem with just going by a visual could be hyperthyroid, euthyroid, meaning they have a normal thyroid function, or hypothyroid function. So the term goiter simply refers to the abnormal enlargement of the thyroid gland. It's important to know that the presence of a goiter does not necessarily mean that the thyroid is malfunctioning. A goiter can occur in a gland that is producing too much hyperthyroidism, too little hypothyroidism, or the correct euthyroidism amount of thyroid hormones. A goiter indicates there's a condition present which is causing the thyroid to grow abnormally. So what are the reasons this can occur? What are the causes of a goiter? Globally, one of the most common causes of goiter formation is iodine deficiency. And because of this, the gland cannot make enough thyroid hormone. Remember, we bring in iodide from the blood. And so if you don't have enough in the blood, the thyroid is not going to make enough MIT and DIT and thyroglobulin. Therefore, the individual becomes hypothyroid eventually. Consequently, the pituitary gland will secrete more and more TSH. This is to try and stimulate the synthesis of thyroid hormone, and also to stimulate thyroid growth, which then causes the goiter. In the U.S., this is not very common anymore because they started to add iodine into foods and salts, as well as in some cases in water. Hashimoto's thyroiditis is a more common cause of goiter formation, especially in the U.S. This is an autoimmune condition in which there's a destruction of the thyroid gland by one's own immune system. And we'll talk about how that works. And this causes enlargement as the gland becomes more and more damaged. It's less able to make adequate supplies of thyroid hormone. The pituitary then senses this, you get that feedback, and more TSH is secreted, again causing the thyroid gland to grow. And then we'll talk more about antibodies and thyroid shortly. Okay? So, let's talk first about primary hypothyroidism. This is commonly called, in some cases, thyroid inflammation or thyroiditis, and this can be caused by viral infection, or in some cases bacterial, which is quite rare. It typically results in elevated thyroid hormone levels in the blood due to thyroid destruction and release of thyroid hormones into the bloodstream. And it is not due to excess production. So you start to get destruction, T4 and T3 are reduced. The hypothalamus and pituitary responds by driving more production of TSH. We have more production of TSH and decreased T4 and T3. So as I mentioned, this typically results in elevated thyroid hormone levels in the blood due to thyroid destruction after you get destruction of the tissue and release of thyroid hormones into the bloodstream. This will lead to a short period of hypothyroidism, which may last a few weeks to months, because remember of the half-life of these hormones, after which thyroid function will recover. In the autoimmune thyroiditis, in this case you have those antibodies, thyroid function may not recover, resulting in permanent hypothyroidism because you've lost some of your tissue. So in the case of it's a viral infection, it will be typically it'll be temporary. In the case of antibodies, it will be more permanent. For women that are pregnant, you can, in 5 to 10%, you will have postpartum thyroiditis. And this is characterized by a hyperthyroid phase within 4 to 6 months of delivery of the baby, followed by a hyperthyroid phase with subsequent restoration of normal thyroid function. Permanent hypothyroidism eventually develops in around a third of those patients. The treatment for this is the disease is self-limiting, and the treatment is not usually required. Usually the body would readjust and the thyroid readjusts so that there's no issues. For neck and pain tenderness, for people that do have thyroid issues, you will treat with anti-inflammatories, and in rare cases you will treat with steroids. In terms of a thyrotoxic phase, which is followed by a hypothyroid phase, it may require a short course of thyroid hormone replacement until the thyroid follicle cells fully recover. This would be in the case of bacterial infection or viral infection. So, the most common cause of primary hypothyroidism is the autoimmune that I mentioned to you, some sort of infection, or in rare case, antibodies against TSH. And it can be this thyroiditis, which can be viral or human or immune. It's Hashimoto's that we'll talk about. Occasionally, it can also be induced by side effects of a drug, and we'll talk about that. For example, in patients that are being treated for depression, lithium can cause thyroiditis, and some of the SSRIs, amiodarone. And then in some cases, in a very few cases of postpartum. In some cases where a patient has been treated for hypothyroidism, you can get a short response when that's called a latrogenic response, where after the treatment you become hypothyroidism. So you're treating someone for hyperthyroidism and they become hypo because their body's responding. And then you can also have, in some cases, again, rather rare, you can have congenital hypothyroidism, and then in some countries you can have severe iodine deficiency in the diet, and this can also lead to inability to make thyroid hormones, and then inflammation of the gland. So, in the case of this autoimmune condition of Hashimoto's thyroiditis, you can see very quickly the gland is very irregular in shape, and in the histology there's a prominent lymphocyte infiltration. You can see these white, you can see these very different pathologies of infiltrate that have come in and some discoloring white versus purple, okay? And presumably some of these are white bloods or blood vessels that have become enlarged because due to the inflammation. So here's a thyroid, inactive thyroid that contains large amount of colloid, okay? And then here is that infiltrate that I mentioned to you just to compare. So this is Hashimoto's thyroiditis with prominent lymphocyte infiltration and inflammation, okay? So you can see you don't have these nice big round follicles. You don't have very clear colloid definition. You have massive small number of cells here that are your immune cells that have infiltrated here in purple, and you can see clearly there's something wrong. What about in the cases of secondary hypothyroidism? This is caused by diseases of the hypothalamus or pituitary. So in these cases, there's actually something wrong with production of TSH or production with TRH, and this has a knock-on effect on the thyroid itself. And this is going to, because you don't have stimulus of TSH onto the thyroid gland, you will drive down T3 and T4. In the case where the secondary hypothyroidism is a secondary hypothyroidism is in the hypothalamus, pituitary, you may have symptoms that are additional to those of the primary hypothyroidism, okay? So if your pituitary is not working, you could have headache, diplopia, or reduced peripheral vision caused by an intracranial mass. You could have skin depigmentation, atrophic breasts, galactorrhea, amenorrhea, erectile dysfunction, Cushing's disease, or acromegalia, depending, all because of the pituitary dysfunction. So some of those things that Carlos would have told you about. This would be in conjunction with low TSH and low T4 and low T3. Now, what is this Hashimoto's thyroiditis? It's the most common cause of hypothyroidism in areas where iodine is readily available. So 45 to 65 is typically the age group with some children, and it has a very large sex bias. Familial cases are recorded with abnormal gene identified in only a small percent. And it's considered an autoimmune disease. So the immune system, it's not, in some ways, we'll talk about that when we talk about diabetes, but it's the same idea. The immune system destroys its own thyroid tissue. And this progressive depletion of the thyroid cells by inflammation becomes replaced by fibrosis, which impedes the ability of the organ to function, and you then drive down your thyroid hormone levels and increase TSH because your hypothalamus and pituitary are trying to say, hey, what's wrong? Why aren't you making our hormone? Now, remember I mentioned to you that you could get thyroid hypothyroidism as a side effect of drug treatment. So in this case, sorry, amiodarone, it's not an SSRI, I apologize, I forgot it's for heart rhythm. It must be, I believe, in a beta 2. I don't remember the target actually. in the case of lithium, it's often treated for depression. So, but one of its side effects can be causing disruption of thyroid hormone production. And lithium is often used for bipolar and for depression. And amiodarone is used for treatment of the cardiac arrhythmias. So apparently, interestingly, amiodarone has a high iodine content, which causes direct toxic effects to the thyroid follicular cells. It can cause hyper or hypothyroidism depending, and the patient taking the drug should have a thyroid function test before starting the treatment. And then if the treatment is continued, have that test or monitored every 6 months. Hypothyroidism incidences can be as high as 13% in patients that are being treated with this drug. The drug does not need to be stopped. It's simply you need hormone replacement. So you would combine, if for these small percentage of patients, you would combine hormone replacement therapy with treatment with the amiodarone drug. In a very rare cases, you get hyperthyroidism, and in this case, you would have the patient stop the arrhythmic compound, and it would take a time to clear because of the long half-life. If by some chance the patient has severe arrhythmia and they cannot be stopped on this amiodarone, then treatment with CBZ is carbazole, if I recall, or plus or minus propanol, which is again a beta. These are adrenergic drugs as per usual. In the case of lithium, it can cause hypo or hyperthyroidism. As I mentioned to you, the hypothyroidism is more common. It affects 5 to 15% of patients on long-term lithium treatment. And it does this apparently by inhibiting release of the thyroid hormone. It's a bit unclear how that happens or why that happens, and the mechanism of lithium is one of the many mysteries of pharmacology. But it can block the action of the thyroid stimulating hormone and enhance the peripheral degradation of thyroxine. So most patients have enough thyroid reserve to remain relatively euthroid and adjust during the course of a lithium treatment. But occasionally you get patients that cannot. And then you just treat them with conventional thyroxine replacement therapy. In hyperthyroidism, which is very, very rare, it's still, as I mentioned, a bit of a mystery how or why that happens, mainly because we don't really understand fully all the mechanisms and all the things that lithium actually binds to. So how do we know or diagnose someone with hypothyroidism? So we first examine the patient for all signs and symptoms of hypothyroidism, obviously the goiter that we're looking for, the physical signs, the face puffiness, or some of the other things that we talked about for changes in their hormone levels, physical changes. And then we would perform a thyroid function test. Now, this is where I mentioned to you, remember I asked you which hormone would we try to measure first? We actually try to measure TSH levels and then the T4, free T4 levels, not plasma bound, it's too difficult. And then if we have trouble or we see something that is not clear from TSH and free T4 levels, then we'll try to measure free T3 levels. But because of the short half-life of free T3 and the percentage that is majority free T4, we will predominantly measure free T4 and TSH. Some individuals may have high TSH with normal thyroid hormone levels, and this is a condition known as subclinical hypothyroidism. Any subject with low plasma thyroid hormones and low or normal TSH should be suspected of having secondary hypothyroidism, and urgent investigations or endocrine referrals should be made. And then you can check for thyroid antibodies to determine if it's autoimmune hypothyroidism. So one of the common antibodies are antibodies against TPO. And do you remember TPO is that enzyme that is responsible for trapping iodine after it crosses the membrane, right? So it converts iodine to iodide, and it's a key step in the process. And in this case, typically no imaging of the patient is necessary. You can just measure these by blood tests, and you should be able to make a diagnosis. What about subclinical hypothyroidism? In this case, you will see a raised or high TSH, but you will have a normal free T4 and free T3. So subclinical just means that the patient has no symptoms yet, but it's very misleading because a large proportion of these patients will have mild symptoms that they have not recognized, or you as the clinician will not have recognized yet. And in many cases, it's caused by an autoimmune hypothyroidism. So the patient will have a viral infection or a bacterial infection. Now, I don't know, it actually would be interesting to know, and I haven't looked, if any of the COVID-19 patients have had hypothyroidism due to an autoimmune response. I'll try to look that up out of curiosity, just to know. Because I know for viral infections, sort of severe viral infections, it can cause hypothyroidism. So, in this case of raised TSH but normal free T4, what you would do is you would perform the TFT measurements again within 3 months. And if the TSH again remains high or is increased, then you might consider starting the treatment for the patient. And this, you would also then test for these autoantibodies, the TPO, and just make sure that the thyroid is not impeded. And what you're trying to do by treatment is to normalize the TSH levels. So the hope is you can provide some free T4, some thyrodoxine, and this will feed back and turn off the pituitary and lower the production of TSH. So what are some of the normal ranges for thyroid function tests? Normal ranges in general when you're looking at a patient's blood levels would be 0.35 to 5, and then over 5 you start to flag it. Even close to 5 you would start to flag it. Free T4 would be below in the range of 10 to 24, and then plasma free would be 3 to 9 picomoles per liter, and then plasma total would be 55 to 144. It just depends on how it's reported. And then plasma total T3, 0.9 to 2.6. You usually only measure TSH and free T4 is enough. Usually just measuring, TSH and free T4 is enough to make a diagnosis for a patient. And then remember, the challenge, obviously, for measuring free T4 is quite a number of proteins bind thyroid hormones, right? Remember that TPG and then albumin, right? So there are at least 3 or 4 proteins which can bind thyroid hormones. Now, the key is remembering and both interpreting and thinking about how do we treat patients. So thyroid doesn't work by itself. It's all about this thyroid axis and the negative feedback regulation therein. So what is not working properly? You have to understand when you measure something, what is it not working properly and what is driving the system? So just as a quick reminder, hypothalamus produces this TRH, releasing hormone. Pituitary stimulates thyroid stimulating hormone, TSH. Both of these are positive. Production. That's going to leave production and release of T3, T4. These are going to feed back to both the pituitary and the hypothalamus, saying, okay, we have enough T4 and T3, turn down TRH and turn down TSH. Okay? So understanding this system as a clinician will allow you to understand how you treat your patients. So with that in mind, a step-by-step investigation and diagnosis of hypothyroidism. The patient presents with symptoms, okay? You test them. Perform TFT, check for TSH, check for free T4. Normal TSH and normal free T4. So what do? Nothing. Patient's normal. We leave them alone. What if it's high TSH and the normal FT4? Remember, that's that subclinical hypothyroidism that we talked about. So in that case, you might measure again in 3 months. High TSH, low FT4. In this case, right away you know something's not right, and it must be primary hypothyroidism. If it's low to normal TSH and low free T4, it might suggest something else is wrong besides something else is wrong. And it's not the thyroid gland, but it's something like the pituitary, for example. So here's some likely diagnosis. And this is a good study slide for you for some popular exam questions. So, what else would you do next? After the thyroid function test, this TFT, you can test for thyroid autoantibodies that we mentioned about, the anti-TPO, to determine whether it's caused by an autoimmune condition. Now, there are different types of thyroid antibodies. TPO is not the only one. But the one test for hypothyroidism is typically the one against the thyroid peroxidase, that TPO antibody that I mentioned. Now, there are other antibodies that can cause hyper, but typically for hypo, it's the TPO. If there is if you find that there is antibodies to TPO, it would be then an autoimmune disease. And then you can try to figure out what the risk is and what the causes are. If the autoantibody test is negative, the result does not mean there is no autoimmune disease, but obviously the positive results would confirm the diagnosis. So you can't count it out always with a negative result, but a positive is definitely an affirmative. And then typically, as I mentioned earlier, for hypothyroidism, blood tests usually can provide the answer to you. And you don't usually need to provide an ultrasound scan of the neck. So what are some of these antibodies? The thyroid peroxidase antibody is the most common one that I've been mentioning, and it's the most common test for autoimmune thyroid disease. And this is known as Hashimoto's disease, Hashimoto's thyroiditis. You can also have antibodies to thyroglobulin itself, and this antibody targets thyroglobulin. And you can imagine this can be quite debilitating for function. You can also have antibodies against thyroid stimulating hormone receptor. And this includes two types of autoantibodies that attach to the proteins in the thyroid to which TSH normally binds to. This can also lead to a thyroid stimulating immunoglobulin, which binds to the receptors and promotes production of thyroid hormones. This would lead to hyperthyroidism or Graves' disease. So in this case, it's an antibody that turns on the receptor. And then in other cases, you can have an antibody that's inhibitory that blocks TSH binding. And so you would have hypothyroidism. So it inhibits production of thyroid hormones because TSH cannot bind to the receptor. The second one is routinely tested for, but the first one is often used only to diagnose Graves' disease. Why don't we take a short break here, guys, and then I will. We can come back in 30 minutes and finish off hypothyroidism and tackle the next one.